The topic given to me today is From Collapse to Courtroom, Understanding Amniotic Fluid Embolism and its Legal Footprint. Mrs. X, a primary gravida, was admitted in labor room on March 23, 2017 for a planned normal vaginal delivery. Labor was medically augmented due to slow progress with proper monitoring. Patient requested epidural analgesia and a senior anesthetist gave it. Throughout labor, patient was under continuous pulse oximetry, non-invasive blood pressure monitoring, and electronic fetal heart monitoring. At 5:40 p.m. on March 24, she experiences breathlessness and oxygen saturation drops to 88%. Oxygen supplemented, she was fully dilated, relatives counseled and consent for assisted vaginal delivery taken. A forceps-assisted vaginal delivery is conducted at 5:50 p.m. to shorten the labor. Mild PPH was managed conservatively. Relatives informed, documentation done. At 7:30 p.m., a second event of desaturation up to 80% occurred. A clinical diagnosis of amniotic fluid embolism was made and later confirmed by positive D-dimer test. Patient was managed with a Venturi mask, low molecular weight heparin, and corticosteroid bolus before being shifted to ICU. Relatives informed and information documented. ICU management was looked after by the multidisciplinary team, that is physician, anesthetist, chest physician, and a consultation with Sir Gangaram Hospital which concurred with the treatment plan, and relatives informed. BiPAP converted to ventilatory support after consent. Soon the patient developed DIC and ARDS and was declared dead at 12:57 a.m. on March 25, 2017. Post-mortem offered, refused, but not documented as husband was very upset and so was the gynecologist. So, amniotic fluid embolism. It's a rare but catastrophic obstetric emergency caused by the entry of amniotic fluid or fetal material into the maternal circulation. It is characterized by sudden cardiovascular collapse and coagulopathy. It occurs during labor or delivery or may occur within 30 minutes postmortem. Incidence is 1 in 20,000 to 50,000 deliveries. Mortality is very high to the tune of 60 to 80%. Litigation risk is very high because of it is unpredictable and has a very rapid progression. Neonatal survival is 70%. The risk factors for amniotic fluid embolism are advanced maternal age, multiparity, placental abruption, induction of labor or cesarean delivery, a short tumultuous labor, use of uterine stimulants, placenta accreta, rupture uterus, multiparous women with a large baby. Current data suggests that the process is more similar to anaphylaxis than to embolism. Term anaphylactoid syndrome of pregnancy has been suggested for this presentation now. The pathology is that the amniotic fluid and fetal cells enter the maternal circulation, possibly triggering an anaphylactic reaction to the fetal antigens. Clinical symptoms result from mast cell degranulation with the release of histamine and tryptase and from activation of the complement pathway. The phase 1 is cardiopulmonary collapse, the pulmonary artery vasospasm with pulmonary hypertension and elevated right ventricular pressure causing hypoxia. The symptoms are sudden hypoxia, severe hypotension, dyspnea and cyanosis, which is followed by cardiac arrest. Hypoxia causes myocardial capillary damage and pulmonary capillary damage, left heart failure, and acute respiratory distress syndrome. Phase 2 is coagulopathy, massive hemorrhage with uterine atony and DIC. DIC, massive hemorrhage and multi-organ failure is the presenting symptom. So the clinical presentation of AFE is generally very dramatic. Blood pressure may drop significantly with loss of diastolic measurement. Labored breathing and tachypnea may occur. Patient may experience tonic-clonic seizures. Cough usually manifests as dyspnea. As hypoxemia progresses, circumoral or peripheral cyanosis and changes in mucous membranes may manifest. Fetal bradycardia in response to hypoxia may be the first presenting sign. Uterine atony usually results in excessive bleeding after delivery. Patient lands up in pulmonary edema, cardiac arrest. In later stages, acute dyspnea and hypotension with rapid progression to cardiopulmonary arrest ensues. 40% of cases are followed by some degree of consumptive coagulopathy. The differential diagnosis is anaphylaxis, aortic dissection, cholesterol embolism, myocardial infarction, pulmonary embolism, or septic shock. Now, management and medico-legal safeguards include in the immediate action, activate multidisciplinary emergency team. Airway management and oxygenation has to be ensured. IV access and aggressive resuscitation has to be carried out. Correct coagulopathy and hemorrhage, maintain hemodynamic stability, emergency delivery, if indicated, has to be conducted, and the obstetrician at the same time has to be alert about the medico-legal challenges and the safeguards. The diagnostic criteria we all know is sudden hypoxia, sudden hypotension, acutely severe hemorrhage, onset of labor, or within 30 minutes postmortem. The diagnostic workup includes ABG is done immediately to determine acid-base status. This should demonstrate respiratory acidosis. Pulse oximetry for continuous monitoring for hypoxia is to be carried out. Coagulation profile, that is PT-APTT, which is expected to be prolonged. Blood grouping and cross-match for potential blood transfusion and transfusion of products is to be carried out. Supportive biomarkers, D-dimer, insulin-like growth factor binding protein 1, low C3, C4 complement levels may also be associated. Treatment is administer oxygen to maintain normal saturation, initiate cardiopulmonary resuscitation if the patient arrests, treat hypotension with crystalloid and blood products, consider pulmonary artery catheterization in patients who are hemodynamically unstable, continuously monitor the fetus, quick delivery has to be conducted, perform emergency cesarean delivery in arrested mother who are unresponsive to resuscitation, hemorrhage controlled with bilateral uterine embolization may be required. Patient is now shifted to ICU. To assess the effectiveness of treatment and resuscitation, it is prudent to continuously monitor ECG, PO2, CO2, and urine output. Central venous pressure monitoring is important to diagnose right ventricular overload and guide fluid infusion and vasopressor therapy. Blood can also be sampled from right heart for diagnostics. Pulmonary artery and capillary wedge pressures and echocardiography are useful to guide therapy and evaluate left ventricular function and compliance. An arterial line is useful for repeated blood sampling and blood gases to evaluate the efficacy of resuscitation. If DIC ensues, it results in depletion of fibrinogen, platelets, coagulation factors, especially 5, 8, and 13. The fibrinolytic system is activated. Most patients will have hypofibrinogenemia, abnormal PT-APTT, and low platelet count. Treat coagulopathy with fresh frozen plasma for a prolonged APTT, cryoprecipitate for fibrinogen if levels are less than 100, and transfuse platelets if platelet count is less than 20,000. DIC results in depletion of fibrinogen. The uterine atony is best treated with massage, uterine packing, and oxytocin or prostaglandin analogs. Improvement in cardiac output and uterine perfusion helps restore uterine tone. Extreme care should be exercised when using prostaglandin analogs in hypoxic patients, as bronchospasm may worsen the situation. The symptomatic mimetic vasopressor agent as dopamine may be used because it increases myocardial contractility and systolic BP with little increase in diastolic BP. It also dilates the renal vasculature, increasing renal blood flow and glomerular filtration rate. Dose is 2 to 5 mcg per kg per weight per minute IV. Titrate to BP and cardiac output. Contraindications are ventricular fibrillation, hypovolemia, and pheochromocytoma. Now, maternal death usually occurs in one of the three ways, that is sudden cardiac arrest, hemorrhage due to coagulopathy, initial survival with death due to acute respiratory distress syndrome and multiple organ failure. For women diagnosed as having AFE, mortality rates ranging from 26 to 86% have been reported. The variance in these numbers is explained by dissimilar case definitions and possibly improvements in ICU management in affected patients. Now, other issues are you have to transfer the patient to a level 3 hospital immediately if you are working in a nursing home. Deterrence or prevention is impossible because amniotic fluid embolism is an unpredictable event. Risk of recurrence in subsequent pregnancy is unknown. The recommendation for elective cesarean delivery during future pregnancies in an attempt to avoid labor is controversial. Perimortem cesarean delivery after 5 minutes of unsuccessful CPR in arrested mothers, an abdominal delivery is recommended in the casualty itself. Now, what are the medical or legal pitfalls? Important pitfalls are failure to respond to emergency. Amniotic fluid embolism is a clinical diagnosis vague or vague. Steps must be taken to stabilize the patients as soon as the symptoms manifest. Failure to perform perimortem cesarean in a timely fashion is a pitfall. Failure to consider the diagnosis during legal abortion is a pitfall. A review of literature indicates that most cases of amniotic fluid embolism have occurred during late second trimester abortions. Multidisciplinary team involvement is very important. If not involved, then you are in soup. Communication and documentation is mandatory, and we all know its importance. So, failure points are delayed recognition, safeguard is early and rapid identification. Failure point is poor documentation. It's important to maintain detailed records meticulously at every clinical action. Non-adherence to protocols can put you in problem, so strictly adhere to clinical protocols. Communication failure is a problem, so transparent dialogue with family is mandatory. Now, this patient's husband filed a medico-legal case in Delhi Medical Council in 2017, questioning epidural analgesia, forceps delivery, inappropriate care, and negligence. The important points when you receive a legal notice is that the reply has to be filed within the time frame allowed. Photocopy your file record and keep it with yourself. No tampering must be done in the file. Always discuss the case with your reliable seniors. They will give you confidence and wisdom. Discuss case with your lawyers. Frame the reply yourself with appropriate references. Save them in your file and let the lawyer add legal language. Engage your indemnity insurance team. Each paragraph or point in the case has to be replied point-wise only in minimal words. Don't get emotional, be practical. If case is on multiple persons in the team, stay united, never part. Ensure that all your residents are covered in the indemnity insurance, even in government hospitals. A case against them without backup is traumatic for them, so protect them. Now, the final order on this case was received in 2019 from the Delhi Medical Council. It concluded that the administration of epidural analgesia and the use of forceps for delivery were conducted under proper consent and followed accepted professional protocols for managing fetal-maternal distress. In absence of an autopsy, the council agreed that the hospital's clinical diagnosis of amniotic fluid embolism leading to DIC and ARDS as the most probable cause of death. Records indicated that the complainant was regularly updated and counseled regarding the patient's deteriorating condition and guarded prognosis between 7 to 12:30 a.m. While the council noted it was desirable to have an autopsy for young patient, they could not reconcile conflicting claims regarding whether a postmortem was offered, as there was no documentation of a refusal in the hospital records. The council determined that no medical negligence could be attributed to the gynecologists and the complaint was dismissed. This husband then went to the National Medical Council. Again, it was proved that there was no medical negligence and complaint was dismissed. In the consumer court, the husband did not appear because he had lost at Delhi Medical Council and at National Medical Council. Now, there's another case, Dr. K. Srikar Reddy versus Srishti Associates. Patient was admitted in active labor, epidural analgesia given labor-induced accelerated. She developed certain cyanosis, convulsions, cardiorespiratory collapse in early hours. The case sheet and MCH intimation later recorded cardiopulmonary arrest and descent to amniotic fluid embolism. Complainants alleged negligent management, delayed theater shift, inadequate resuscitation, tampering of records, and failure to perform autopsy. Failure to monitor and resuscitate promptly, inappropriate drug administration, patient left supine without wedge, delayed theater shift, inadequate oxygenation intubation, and omission of DC shock, causing preventable collapse and death. The defense was doctors responsibly argued AFE is a known, unpredictable obstetric catastrophe. Advanced resuscitation was provided, airway intubation attempts made, and no documentary evidence showed procedural lapse. They denied tampering and said relatives refused post-mortem. Expert opinions relied upon by the defense accepted AFE as probable. The commission examined records, expert evidence, and medical tests. It applied the standard that negligence requires proof of breach of reasonable professional standards. On the facts, the complainant failed to prove the treating team's conduct fell below that standard. The court highlighted that AFE can be sudden and often unpreventable, and that mere misfortune or tragic outcome is not proof of negligence. So the verdict was not guilty. Dr. L. Sudhakar versus Medical Council of India. This writ petition was by an anesthesiologist challenging MCI disciplinary order, which had struck his name off the register for 3 months following an appeal arising from the death of a patient, where AFE had been recorded as the cause. The underlying facts mirror the Shalini nursing home case. The complainant had alleged negligence leading to death. The MCI's ethics committee found professional misconduct and recommended suspension of anesthetist. Petitioner argued lack of jurisdiction, procedural unfairness before the MCI. He also contended facts pointed to AFE, a rare unpredictable event, and that the State Council had earlier found no negligence. The Andhra High Court did not decide guilt on merits. It set aside the MCI order on procedural natural justice grounds and remitted the appeal back to MCI for fresh consideration with the proper hearing. The court recognized AFE as a rare, often unavoidable catastrophe, but judgment turned on procedural fairness to the practitioner. Verdict was procedural relief to the doctor. No final finding of negligence was there. Dr. Manisha Agarwal versus V. Kapil Bajaj. Patient admitted for labor cesarean. After delivery, she suffered sudden arrest, remained comatose. State Commission held that treating doctor or hospital was liable and awarded compensation. The doctor appealed to NCDRC. The treating team suspected AFE and performed resuscitation and timely referral to the higher center. Allegations were inadequate investigation, absence of proper facilities, delays, wastage of time in OT, lack of anesthetist presence, and negligent management causing neurological injury. Doctors produced records, contemporaneous notes, expert literature, and described immediate resuscitation, intubation, and ventilatory support and transfer to a tertiary center. They argued that AFE is unpredictable, unpreventable, and the treatment met accepted standards. The UP Medical Council had not held the doctor guilty of negligence. NCDRC reviewed medical records and medical literature on AFE. It emphasized AFE is unpredictable, catastrophic. On record, NCDRC found no breach of reasonable medical standards and allowed the appeal, that is, quashed the State Commission award. The order contains a careful discussion of when AFE can be considered an unavoidable complication versus when procedural lapses attract liability. So the verdict was again not guilty. So we are seeing that in all these cases, finally, the verdict is not guilty because AFE is expected to be an unpredictable event. Another case, Rajendra Sadanand Jujare, second cesarean performed, patient later developed convulsions, massive deterioration, died the same day. Post-mortem and medical evidence considered, AFE or eclampsia discussed, complainants alleged negligence in post-op monitoring and delayed transfer. Allegations, failure to monitor BP, SpO2, inadequate post-op care, delay in shifting, lack of appropriate response to neurological signs. Defense was that OPs produced records, history of PIH in earlier pregnancy, and argued that convulsion, eclampsia, and AFE caused sudden deterioration. The resuscitation measures were taken and patient was transferred to higher center promptly. NCDRC examined the records and medical literature. The commission found that the medical records and treatment steps were credible, held that post-mortem findings were consistent with fatal AFE, concluded that there was no negligence in cesarean, post-op care or complaint was dismissed. Verdict was not guilty. So in all these situations, it's very important that we must offer post-mortem to every patient who faces such kind of a situation. This is Dr. Srivani, who recently lost her life to amniotic fluid embolism, and she has been the inspiration for this webinar today when Dr. Sharda gave me this topic. So to conclude, AFE is rare, catastrophic, and often fatal. It can occur despite best medical care. The defensive strategy is preparedness. Regular team training and upgradation of facilities in your facility is important. Documentation and communication is critical. Ethical and emotional aspects of the fatal outcomes lead to an emotional toll on family as well as the healthcare provider. Support to families must be provided. Offer grief counseling, and support to clinician must always be provided. Provide debriefing session and medical legal education. Senior and medical administration should stand by such a consultant. Thank you very much.